Hello everyone, good afternoon and welcome to the latest edition of the Men's Health Month series with Vitality. My name is Jamie and I am part of the coaching team at Vitality. And today's conversation and topic is one of the most important that we'll ever cover. In 2020, there were over 3 million people in the UK living with cancer. And really sadly, around 165,000 people a year die from the disease. The evidence is pretty clear that early diagnosis and treatment is crucial for long-term survival. The conversations that we are having are not easy, but they are really, really important. So for anyone joining today, I think the first thing to say is, please do exercise self-care. And the message throughout this is simple: seek medical support if you have any concerns whatsoever. But focusing specifically on men's health, an apparent obstacle for us all seems to be the reluctance to consult a doctor. I feel that we're all pretty guilty of it. I know that I 100% am, but I have absolutely no idea why that is. But there's movements happening, such as Movember, which are changing the face of men's health. And by 2030, the aim is to reduce the number of men dying prematurely by 25%. But there is still currently a lot of work to do. 88,000 men a year are diagnosed with cancer, and there are many, many more who are going undetected. Raising awareness, I think, for the kind of male-specific cancers is a huge part of this. And although there are more than 200 different types of cancer, some are more prevalent in men than women. So for today's session, we'll be focusing on prostate, lung, bowel, and testicular cancer. We'll be guiding you through the signs and symptoms, diagnosis, treatment, and also, quite interestingly, how to effectively support others, because this conversation goes beyond men. Women are involved too, partners and carers and families. It affects everyone. So for today's session, we're once again so privileged to be joined by Professor Gordon Wishart, who is the founder of Check for Cancer. He's a former cancer surgeon, and he's kind of become the face of our cancer support through these events with Vitality. We're also incredibly grateful to have Chris Roberton join us, who is a Vitality member that has been through treatment for cancer himself. And he's been really kind enough to share his experiences, his learnings, and will no doubt be providing some really valuable advice for everyone watching today. So at this point, what I'm going to do is direct you to the handout section. So on the right-hand side of your screen, you've got a kind of widget board. In the handout section there's 4 documents detailing the signs and symptoms of the cancers that we'll be covering today. All of these have been provided by Check for Cancer, which is amazing. So please do download these, share them far and wide. Everything that we cover today will be in there. And again, we can continue to raise the message after this event is finished. And then the final thing, just for the technicalities, is please also navigate yourselves to the question box. We really need to encourage engagement today because this time is for you. The chances are, if you're nervous or worried about something, someone else most likely will be too. So ask the question. If it's not for yourself, it's for someone else. We'll keep everything anonymous and no one else can see what you've submitted. So the message is consistent today. Please don't ignore it. Say something and speak up. So at this point, that's probably enough of an introduction from me. Let me introduce Gordon, who is always unbelievably generous with his time and such a true expert in the field. Gordon, so good to see you again. Thank you for your time. How are you doing?
Yeah, good. Thanks, Jamie. Good to be back, focusing on men's health this time rather than women's health, which, as you say, was the last webinar.
Yeah, exactly. And Gordon, before we get into that, we spoke yesterday about the challenges of being a male and speaking up and being aware of the kinds of things that we need to be aware of. From your perspective, what's the kind of biggest challenges that you found with working with men? Is it the kind of reluctance to seek medical advice? And do you have any insight as to why men are like that? Because I don't understand myself, to be honest with you.
Yeah, I'm not sure I do either, Jamie, but what you described certainly, prevails more in men than in women. I think we have a tendency to box things away that we see as a challenge, or we're not quite ready to deal with, or we're not sure how to deal with it. And I think, healthcare is one of those things. And I think most men would agree that they ignore things, and it's often only when they get encouraged by their wife or their partner that they actually go and seek help, about whatever their health issue is. And so I think it is a problem. I think men also struggle to know how to react to other men that are having, a problem like being diagnosed with cancer. And that's maybe something we'll talk about a bit later on.
Yeah, for sure. I think all of those points are really valid. And these are the kinds of things that we want to come from today's conversation. So we've got a lot to cover today. We've got 4 different specific types that we're going to cover. A standard structure for, just very informative, and then we'll get on to Chris's story as well. But I think it goes without saying that the effect of the pandemic has been pretty negative on a range of healthcare areas. But the pandemic has also caused particular challenges with certain types of cancer. So we're going to start initially with prostate, lung, and bowel cancer, because actually the signs and symptoms of these 3 may be a little bit less obvious. So just a statistic to start with, Gordon, prostate cancer, Cancer Research UK has reported that there's over 52,000 new cases of prostate cancer each year. But second to that, there's a 78% survival rate of 10 or more years. But again, the message today is kind of about early detection and understanding those signs and symptoms. So if we start on prostate, would you mind sharing the kind of common signs and symptoms that we should be looking out for? And also, I think the age thing as well is important. Like, I'm a younger male, but does that mean that I shouldn't be interested or shouldn't be concerned? Like, if you could just share us a little bit more about that too.
Sure. If we start with age first of all, then prostate cancer is pretty rare under the age of 40, and the risk does increase as you get older. And that's why, you know, I think there've been a number of studies that have done post-mortems on men, and they often say that the majority of men die with prostate cancer, even though it hasn't actually become apparent and affected them in their life. So the incidence increases with age. Roughly about 1 in 8 men will get prostate cancer, but the risk is much higher in African American and African Caribbean men, where the risk goes up to about 1 in 4 men being diagnosed in their lifetime. Now, the challenge with prostate cancer, like lung and bowel cancer that we'll discuss later, is that by the time symptoms develop, it's often, you know, at a more advanced stage than we would like if we're, you know, really trying to improve cancer survival. And we will talk about some of those symptoms, and that's why in prostate cancer screening is important. I know there are differing views about screening, but you know, using PSA testing, which is a simple blood test, and then an MRI scan afterwards, if the PSA is level, is probably the best way to diagnose breast cancer, and it's probably the best way to pick it up early. I'm not saying that everybody who has symptoms of prostate cancer is at an advanced stage, but in general, you know, that would be the case. And we know that during lockdown, the delays to prostate, lung, and bowel cancer are already showing that it's now presenting on average at a more advanced stage than it was before lockdown. So the kind of symptoms to look out for is that the prostate gland sits under your bladder, and if it gets big, it really blocks the flow of urine coming out your bladder. So you have to go more often to the toilet. You often get up to pass urine during the night. You often find that you maybe just can't start your flow of urine as well as you used to be able to. So it's all to do with restricting the flow of the urine out of your bladder. You can also get some pain in your pelvis, but that's a very, you know, nondescript symptom, and you know, something that probably people would be struggling to work out what on earth was going on. You might also notice some blood in your urine or some blood in your sperm. Those are the other symptoms that you know, can raise concern.
Okay, cool, perfect. So it's ultimately down to enlargement of the prostate gland, and then that will likely, the most common and obvious effects are through urine, so either blood in urine or sperm, or just needing to go to the toilet more frequently. So it's pretty specific then, you would say, Gordon. There's not much else to be
it sounds like it should be pretty. I think that the blood thing is a bit more specific, but actually as we all get older, we all suffer from a benign condition where the prostate gland gets bigger. And that's the challenge, because the symptoms of that are exactly the same flow restriction symptoms that I've described for prostate cancer.
Yeah.
And that's where the challenge is. So we would all expect to get some of these symptoms when you get older, but which of us have got prostate cancer? How do we find that out?
Yeah, and that leads us on to the second point really nicely, is about the diagnosis process, because that is a massive question for men. And I think it's also like a stigma attached to the prostate assessment, what's involved. So would you mind sort of detailing what the process is for diagnosis, and then also kind of the steps that men need to take along the way and be conscious of, I guess?
Sure. So I think if one of us went to our GP with some of the symptoms like I've described, then the first thing the GP would do would be to do an examination to see whether you can feel whether the prostate gland is bigger than normal or does it feel abnormal. And they would check the PSA, so that's prostate specific antigen, which is a blood test. And we know the normal range for PSA, and we know the normal range for different age groups. So if your PSA is elevated for your age group, your GP would probably check it again to be absolutely sure before referring you on to a urologist, which is a surgeon that deals with prostate and other men's cancers, and they would almost certainly now organise an MRI scan of the prostate. In the past, until about 5 years ago, the majority of men with a raised PSA would go straight to a biopsy of their prostate gland. But that would be a kind of blind biopsy without knowing whether there was something going on in it or not. With an MRI scan, it can show if there is an abnormality in the prostate gland that's likely to be malignant or is suspicious of a prostate cancer. And that allows us to choose which patients to biopsy. And then because you know which part of the prostate gland the abnormality is in, you can target your biopsy to that particular part of the prostate. And so now with that combination of PSA and MRI scanning, we can pick up prostate cancer, much more easily, and we're more likely to pick up more aggressive prostate cancers with that approach. And also, we're going to stop doing some of the unnecessary biopsies that we used to do just because your PSA was raised.
Yeah. So the sort of screening diagnosis process has become much more specific, I guess, because you're not biopsying everyone and you're being more specific where the biopsy is taken from.
That's absolutely right. And so if someone is found to have a raised PSA because they've had screening, then they would just go into that same diagnostic pathway, MRI scan, and then just as I've described.
Amazing. Cool. Thank you, Gordon. That's very helpful because the point of today is about honest conversation. A lot of questions that we had was men being concerned about a physical examination, obviously feeling for like enlargement of the prostate. Does that still exist? And I guess, should men be concerned about what's involved if it does?
Yeah, it is still around, and it's something that the GP would still normally do, and the urologist, when you go to see them, might also do. It can be uncomfortable, and I know it is almost certainly something that most men would feel pretty uncomfortable about it. But at the end of the day, there are lots of clinical examinations that men and women have to go through that are upsetting or threaten their privacy, but it is part of the clinical examination, so it does still exist.
Yeah, I think that's your point, is that like it is part of it, but the outcome of knowing is far better than not. So always do get it checked. And we are getting quite a few questions in, so I'm going to chuck a couple of them in now because they are very relevant. The first one is, what would you consider a worrying PSA score for someone around the age of 60? And I guess that's a really tough question to ask because everyone is individual and needs to know their own numbers. But is there guidelines or anything that you should particularly be looking out for?
It is. There's an age range for each kind of each decade, if you like, 40 to 50, 50 to 60, 60 plus. I'm pretty sure that the level of 5 or more would be an age specific level for someone who's 60 years or above.
Amazing, thank you. But I think the key there is that your GP or your consultant will guide you appropriately.
Yeah.
Amazing. Just we've had another couple that I'm keen to get in at this point. Would a PSA test be able to detect for other types of cancers or pick up any abnormalities?
No. So the PSA stands for prostate specific antigen. So it's only produced by the prostate gland, and it only goes up if your prostate gland gets bigger, and that, as we discussed, that can be a benign thing, or if you have prostate cancer, because the cells are producing more of it.
Perfect. So the final question on this section, again, it's great that there's so many people asking these questions, is about what is it about? Just forgotten. Is about, you mentioned about later life, 60, sort of 40 plus, the likelihood might increase. And someone has asked a question here, should we be regularly PSA screening from, say, the age of 40? And is that something that you would do as a patient, or would you wait for kind of like your doctor to contact you? Is it something we should be more proactive about?
Yeah, if you're going to do screening, and there is a debate about whether all men over 40 should have screening, or whether we should just try and target it to those that are higher risk because of their ethnicity, or because of maybe they have a close family history of prostate cancer. But whatever you do, then starting at 40 would be the normal age to start. And the other thing is that just having a one-off probably isn't as effective as, you know, starting at 40. From your level of PSA at 40, you can then determine when the next PSA test should be. For instance, if it's below a certain range, there's no point in testing it for another 8 years, because you're so unlikely to develop prostate cancer. So you can use that initial one to decide the frequency of future PSA screening tests.
Amazing, cool. I'm just going to share one story that we've received as well. Someone said that 5 years ago, they had a company medical and their PSA reading was 17, which suggested prostate cancer. It was retested, and at that point it was even higher. But a digital examination concluded that they had an enlarged prostate, which is not unusual in their age group. But then the urologist spoke to a specialist, and they concluded that the result was so high it might be an infection. So after a course of antibiotics, actually they found that the results sort of dropped, and they were below 3 by the end of that. So is that something that may be common or could happen?
Yeah. That's a great question, and because actually this is worth sharing with everybody that's listening, is that if someone does have symptoms of an infection, so, you know, passing urine is painful, going more often, you know, change in color, and you prove an infection, then that is another reason that your PSA can go up. So you would normally treat the infection, wait for 6 weeks, and then recheck the PSA. And if it comes down, then you know it's been the infection that has caused that.
Okay, that's really helpful, because if you do get a high reading, it doesn't always mean one thing. So I think that's
right.
an important point to make. Amazing. And then just moving on to, if you were to be, worst case scenario, diagnosed with prostate cancer, what sort of the treatment process might look like, and the options that men have available to them?
Yeah, well, you know, 20 or 30 years ago, when I, you know, first started in surgery, the treatment of choice for anybody with prostate cancer was to remove the whole of the prostate gland. But, you know, there are a number of really important structures that are round and close to the prostate gland that would often get damaged during that, particularly the nerves, you know, that cause erections. So damaging those can lead to impotence. You can get infection, and you can also damage the bowel, which is quite close. So there has been a gradual move to saying, like in many cancers, that rather than taking out all of that particular prostate gland, should we just focus on the area where the cancer is? Now, there might be some people where it's present in all parts of the prostate gland, and when you would still need a treatment that you know, took into account all of the prostate gland. But more and more, there are what we call focal treatments, where you might use radiotherapy just to a particular part of the gland. And there is a fairly new technique called high frequency ultrasound, or HIFU, where again you're targeting it to the area where the tumor was. And there is also the option of you know, smaller amounts of surgery. So these are all designed to still treat the cancer effectively, but to minimize the damage to the important structures around the prostate gland.
I think that today's webinar's positioning is important. Like, it's very realistic and real, but also it's really good to hear the progressions that are being made. And speaking to you and working with you on a few of these, Gordons, it seems that everything is becoming much more individualized, and the treatment is much more specific as well. So I think it's really positive that actually it's not just a case of removing the whole thing. It's about understanding you as an individual, and then the treatment suits that as well. So it's not necessarily a positive spin. That's not what we're trying to do, but it's great to see these advancements being made, I think.
Yeah. The only thing I would say, Jamie, is that sometimes having lots of different options can become quite confusing for people, to try and understand, well, how do I choose which is the best one for me? And that's where you really need to rely on the consultant that's looking after you to guide you into what the best options for you might be.
Yeah, definitely. As always, take the medical advice. We're going to move on to lung cancer now, Gordon, because again, there's been amazing interaction already. So please do keep that coming. And lung cancer is an interesting one, I think, because there's been over 48,000 new cases a year that are sort of diagnosed, with only a 10% survival rate for 10 years or longer. But I think that it's really, really important here to mention that 79% of those cases are supposedly preventable, either with appropriate screening or lifestyle risk factors that people obviously could adhere to better. So with lung cancer, Gordon, the long-term prognosis doesn't seem that great, but are there very obvious signs and symptoms that we should be aware of? And I think it's probably important at this point to add on, are there lifestyle factors, obviously, such as smoking, that we really need to be aware of?
Yeah. Well, if you look at the Cancer Research UK website, it says that just over 70% of lung cancer is still directly due to smoking.
Wow.
But having a close family history, a first degree relative, so it could be father or mother, because women get lung cancer as well, your siblings or your children, increases your risk as well. Now, because your lungs are enclosed in your rib cage, it has to be, it's very difficult to detect symptoms. Pain and discomfort could be due to lots of different things. You might have a cough that goes on for longer than normal. We all get a bit of a cough. Sometimes during the winter, it goes on for quite a few weeks. I think if you've got a cough that's lasted for more than 6 weeks, you should get it checked out. If you're coughing up any blood, then again, that's usually, a sign that there's something not right inside your lungs or the back of your throat. So again, that would be worth getting that checked out. But again, because lung is one of those cancers where the symptoms tend to present late, you might get more generalized symptoms. So loss of appetite, losing your weight, looking a bit pale because you're anemic. So a lot of more generalized symptoms, but some particularly specific ones. And this is why there's a big push to try and find the best way to screen for lung cancer, to try and pick it up way before it gets to that point where the symptoms become obvious.
And it's important to say, I think, whenever we've worked on cancer and signs and symptoms, a word that always seems to pop up that I recognize is the unexplained part. So, people get coughs and colds and things like that, but your point there about 6 weeks or more kind of lingering blood, doesn't, the fatigue, appetite changes, maybe a little bit anemic, all of those things which aren't associated with anything else, that's kind of what, you need to have good self-awareness for yourself.
Yeah, I think that's a good point, Jamie, and this would apply to all cancers. Prolonged or unexplained symptoms, are things you should get checked out.
Perfect, definitely. And you mentioned about the diagnosis process there. Would you mind sort of sharing what it looks like maybe with lung cancer? And again, with all of these, how Check for Cancer might be able to support as well. I think it would be really useful.
Yeah. So if someone, went to see their GP with a cough that had gone on for too long, you'd have an examination. Someone would listen to your chest to see if there was any parts of your lungs where the air doesn't seem to be getting into for whatever reason. A chest x-ray would normally be the first way of trying to see if there was anything wrong inside the lungs. Very simple test, easy to do. You can get it done quickly, probably on the same day if you needed to. And then if there's any suggestion of an abnormality or the symptoms are not settling, then you would go on to do a CT scan. So a CT scan involves, lying inside a big chamber where they, it is a type of X-ray, but it gives you pictures which are essentially slices of your body, and you can look very carefully to see, is there any abnormality in your lungs? If you are diagnosed with lung cancer, then the treatment is often surgical, so removing the part of the lung where the cancer is. You don't always have to remove the whole lung, you can remove part of the lung. You sometimes use radiotherapy, and you sometimes use a combination of both. And so it's largely treatments like surgery or radiotherapy that are designed to, to either remove or ablate the area where the tumor was.
Is it fair to say quite invasive surgery then that could lead to some longer term effects?
It is, but like all surgery, if there is the option to do it with keyhole surgery, which is where, you know, we insert a camera and then we put long probes in that we can manipulate the tissue like we would with our hands if we were operating, then some of it can be done with what we call laparoscopic surgery or keyhole surgery as well.
Okay, cool. That's really interesting. A question that we've received from quite a few people is about passive smoking. So kids that have got parents that smoke, or people that are just working in environments where smoking is more prevalent. Does that mean that they are at a higher risk? And if so, what can they do to protect themselves more so? I mean, I assume the answer is probably just removing from the situation.
Yeah, I think the thing about passive smoking is that clearly if you are consistently exposed to, you know, passive smoking, you will have a higher risk. I don't think it is as high as someone who actually smokes, and it's difficult to quantify that risk. But you know, when we say that, you know, smoking is directly linked to lung cancer in about 72% of cases, a large part of the other 28% will be indirect smoking, as well as other, you know, factors.
So that point
removing yourself, you know, it just looks so alien now when you see a car going past you and someone's smoking within it, and there are other people within, you know, the car. It's a pretty unhealthy, you know, thing to do, I would say.
Yeah, I
In
always
such
find
an
it.
enclosed space.
Yeah, like how it was ever a thing allowed in restaurants and bars and things, it amazes me really. Someone has also just mentioned about the handouts where they can find them. So I'll just reiterate, on the right-hand side of your screen, you've got like a questions box and there's a handout section. If you go into that handout section, you've got all of the documents in there. So just make sure you download each of those. And again, everything that we cover today will be in there. So please do keep on sharing. Gordon, we're going to move on to bowel cancer now. And again, the prevalence is really, really high. Cancer research UK suggests that 42,000 new cases of bowel cancer each year, with a survival rate of around 53% for more than 10 years. However, once again, it's suggested that 54% of these might be preventable with adequate measures and screenings and things like that. So are there more obvious signs and symptoms of bowel cancer, or what sort of things do we need to be looking out for?
Sure. I apologise for the noise in the background, but there's clearly some building work going on outside the building I'm in. Yeah.
We've got you clear.
Signs and symptoms of bowel cancer. There are a number. So the term unexplained comes back in here. So unexplained rectal bleeding, so bleeding from your back passage. Unexplained weight loss. Unexplained abdominal mass. Anemia, you know, which by the blood test they can tell is due to you losing blood somewhere, because you might be losing small amounts of blood over a long period of time, enough to make you anemic. If you have a tumour that's growing in the bowel, then it can lead to obstruction of the bowel. And sadly, bowel cancer is one of those cancers that's often diagnosed because the patient comes into hospital as an emergency, because the bowel is either obstructed or it's gone even further than that, it's actually burst. And so we obviously want to try and pick things up before they get to that stage. So bleeding, a change in your bowel habit, losing weight, an abdominal mass, you know, a number of different things like that. And as you say, the survival of bowel cancer isn't as good as prostate cancer or breast cancer. It's not as bad as lung cancer. It's somewhere in the middle. It's about 50% 10-year survival. And as you said, we think about 50% of cases are preventable. And I think it's just worth mentioning how you can prevent that. But, you know, the three main lifestyle factors that are associated with a higher risk of bowel cancer are smoking, alcohol, and being overweight. All things that we can do something about.
So smoking in particular is interesting. It doesn't appear like that would be a direct link. Do you know any reason?
I know, and I don't actually know what the way that smoking has its effect, but it clearly is a factor. And then there's also been this term in the last few years, which is sitting as the new smoking, and that's because, you know, just sitting in chairs at your desk and your computer all day without taking any exercise usually leads to you being overweight, and that's, so it has its effect through that way.
And is that what's meant by the statistics where it says that certain cancers are preventable by X%? Is it lifestyle factors?
It's usually with lifestyle factors which you can, do something about through behavioural change programs, or just because you have the drive to change your own behaviour. But you have to be aware of the risks before that can, be something that you choose to do.
Yeah, I feel like it's an important point to be made though, because there's lots of people that are putting in the comments that people whose parents and other people that they're concerned about. But the first thing to do is to look after your health in general. So not smoke, limit alcohol, exercise, manage your weight. All of those things is really like the first thing to look at. Would you say, is that right?
I think so. Yeah, absolutely. Family history is important in bowel cancer. The more close family members you have who were diagnosed with bowel cancer, the higher your own risk, especially if they were diagnosed at a younger age, under 40. Then, and there are genes that pass down through generations that increase your risk of bowel cancer as well.
I don't feel like that point is made enough, though, that you should be looking after yourself in general as the first thing to do. And then outside of that, being aware of family history and other risk factors that you have less control over.
Yeah, that's right. And that's where, as you say, that's where the preventable part of all the cancers really comes into play. It's lifestyle factors you can do something about.
Yeah. Okay, perfect. So I'm just going to recap again. The sort of symptoms to be looking out for are unexplained bleeding, weight loss, anemia, abdominal swelling, and then any obstruction in the bowel and sort of movement through the bowel as well. Did I get everything there, Gordon?
Yep. And there's a good list of them on the infographic on your handout as well.
Cool, perfect. So again, make sure you get that down right now. So next step will be the diagnosis process again for bowel cancer, and of course, what Check for Cancer can offer too.
Yeah. So if you saw your GP, they would almost certainly do a physical examination. They'd examine your abdomen. Can they feel anything abnormal from the outside? You would have a rectal examination the same way that we examine the prostate gland. And then they would probably do something called a FIT test. So it's a little test where you take a small amount of feces and you detect whether there's any blood in it. Because if you've got blood, unexplained blood coming out of the bowel, then it may be a sign that you either have a cancer in the bowel or a polyp, which is an early change in the lining of the bowel that if you detect it and treat it, you can stop it becoming a bowel cancer. So, and then if that's positive, you would usually go on to what's called a colonoscopy, where they put a telescope into the bowel and they look round the whole part of the large bowel. So it's an examination that would be done under sedation and can take up to an hour. And they look all the way along the lining of the bowel and they look for anything abnormal. And if they see anything, they'll take a biopsy at that time.
Right, so they're visibly like looking out for the cancer.
Okay. Absolutely.
Wow, amazing.
And the cameras are so good, you get this brilliant image of the lining of the bowel. It's like watching, your 4K television. It is super focused.
So they're going to pick up anything at all. That's the last step. Like that's the amazing. And then again, if it comes to the point where you are diagnosed, is there a standard treatment process for bowel cancer?
Yeah, it's you if you pick it up early enough, it's nearly always removing that part of the large bowel and joining the ends up, hopefully, and maybe taking some lymph nodes away to see whether the tumor has spread outside the bowel to the lymph nodes. So for most people, it would just be a removal of part of the bowel. It's still a big operation. Again, it can be done with laparoscopic surgery in a number of cases. So your recovery from that is much quicker if you have it done with keyhole surgery. And 20 or 30 years ago, you would have a massive incision all the way down the middle of your abdomen to allow them to get in to do that. Now with laparoscopic surgery, much less muscle cutting, much less pain afterwards, much quicker recovery.
Amazing, really good to hear. The next and final cancer that we're going to move on to before we hear from Chris is testicular cancer. And although the numbers of diagnoses per year are significantly lower, I think this is a disease that can affect people of all ages, and particularly younger men. As much as we may seem like we're not concerned about cancers, it's definitely one that you should be aware of. So there are over, I think, 2,300 cases diagnosed each year, and with a survival rate of 91% for 10 or more years, which is really, really great to hear. Gordon, would you mind sharing the name of the handout for this one?
Yeah, I think it says something like, have you got the balls to, do a testicular, to examine yourself, something like that.
Yeah,
which is a bit provocative, but as you said right at the beginning, I think as men we need a bit of a wake-up call to looking after yourselves, and so it's purely intended to catch attention for the right reasons rather than the wrong reasons.
Exactly. Yeah, exactly. And that's I guess the first part about this as well, signs and symptoms, and also probably apart from awareness, one of the only cancers that men can physically screen themselves for as well, would you say?
Yeah, so I'm not aware of any risk factors for this, for testicular cancer at all. There are two main types. There's something called a seminoma, something called a teratoma. And there are two peaks of incidence. So you're absolutely right to say that there is a massive peak in kind of early 20s. So that's the first time that we see quite a rise in incidence. And then again, in the 50s, there'll be another peak of incidence. So those are the two main age groups that tend to get this. It's usually detected by noticing that one of your testicles has changed. It's maybe got bigger, or it feels heavier, or it's painful. And if you do examine yourself, you notice that it's bigger than normal, or you notice that it's got a hard bit on it rather than being smooth, which is what the testicle normally is. And so you're right to say it's a very treatable type of cancer. It's usually treated with a combination of surgery and chemotherapy. So the surgery is to remove the testicle. You can put a prosthetic testicle in, to make the scrotum feel the same on both sides and to give some kind of symmetry. But it's essentially removing the testicle, and sometimes removing the lymph nodes in the groin, and sometimes the lymph nodes in your pelvis as well. So you have to have a lot of scanning done before surgery to see what the extent of surgery is that would be, the best treatment for you. So again, that personalized approach, if the tumor doesn't look like it's spread to the lymph nodes in the pelvis, then you wouldn't remove them. So very tailored treatment. And then, the types of chemotherapy that we've had for testicular cancer have been really very highly curative since the late 80s and early 90s. When I trained in Glasgow, they made huge inroads into treating this disease effectively. And then because there are tumor markers that the tumor produces, so they're obviously very high in the blood, those blood tests when you're first diagnosed, you can watch them fall to normal after the treatment, and then you have those checked regularly. And if there's any sign of a rise in them, you have further scanning and then further treatment to whatever area the tumor has come back in. That whole package of treatment is incredibly effective, and is one of the great success stories, I think, in cancer treatment.
Yeah, and it's great to hear that, like, being aware of recurrence and having steps in place to pick that up quickly is available too. And I think women are really good at sort of sharing the message about get to know yourself and feel your own body. And I think men should be doing more of the same thing as well. So definitely one for us all to be aware of. And the more that you get comfortable with yourself and know yourself, the better you'll be at picking up any changes. Gordon, I'm just going to, we've got so much covered here. Again, get to those handouts. Everything that we've said is in there. But just one final thing before we speak to Chris is about the sort of general symptoms, I guess, of that you might just be aware of as a male or as a female as well. But things like fatigue or like unexplained pain or blood loss or lumps, these sorts of things, just as a general rule. Is there anything else that you'd add to that list?
I would just go back to what we were saying a few minutes ago, unexplained or prolonged symptoms. Prolonged, I mean more than 6 weeks. and unexplained you've described.
Okay, perfect, amazing. Thank you, Gordon. You are the biggest source of knowledge in this area, and it's so helpful to have. And again, all of the questions that we've got shows how important it is that we're doing this today, so please do keep them coming. Next up, we're going to introduce Chris, who is a Vitality member and has also been through treatment for prostate cancer, and he's been amazing to share his time with us today. Chris, hopefully you are there. We're going to learn a little bit more about his story, what made him go for the initial checkup. Chris, how are you?
Hi, fine, thanks, Jamie. Hopefully you can hear me.
Got you, loud and clear. Thank you so much for joining us today.
I'm on a bit of a delay if I'm a bit slow, sorry.
Okay, you're all good. It's fine. Chris, would you mind sharing, I guess initially what would be great to hear a little bit about is everything that we've spoken about today about signs and symptoms and awareness. What was it that made you initially go for your checkup?
A number of things. I was having a lot of lower back pain, which turned out to be unrelated. That probably is the main thing. I was having erections weren't as good as they ever had been, and that was the main factor for me. All of the symptoms that the professor mentioned, none of them were relevant to me. Nothing like that. I had none of those symptoms. So, as he said, everybody's different and everybody shows it differently. That's how it came across for me. Was I felt like being kicked up the backside, and whether that was part of it or a symptom, I don't know. But that's how I found it. Went to the doctor, and the doctor suggested I had a PSA test. So I'm 59 years old. My PSA came back at 4.1, which isn't massive, and it didn't set any alarm bells off with myself. But on his suggestion, and for the fact that I had Vitality health insurance, I was able to go for an MRI scan. It was at a time when COVID was on, so if I didn't have Vitality Health, then I would have been stuffed because the government had stopped it. So I was told by my in North Wales, where I am anyway, that's what I was told. So I went for the MRI scan, and that showed an abnormality. So on the back of that, again through Vitality, I had the biopsies, and the biopsies came back showing levels that needed treatment rather than a watching brief. So that's a brief of how I found it, and that happened over a period of about 1.5 to 2 months it took to get all that through.
Okay, so, interesting. Gordon, that's pretty much the process that you explained to us earlier, but the one thing that is quite different is that PSA score of 4.1. Is that, I mean, great work from the doctor, I guess, but is that something that the symptom of lower back pain would be the main thing to look out for?
There are limits to my memory, but I think that even at 4.1, it's slightly elevated for your age.
Yeah.
Yeah. So I think that's why you were sent forward. But it's interesting, Chris and I hadn't spoken about how his diagnosis came to light before this webinar, but it is just as I had described. So I think you were looked after very well. You had exactly the right tests done, and clearly it got to making a diagnosis in quite a fast time, bearing in mind there was still COVID, around.
Yeah, I feel I was very lucky. I was under a very good surgeon in North Wales, and then moved on from him to Clatterbridge on the Wirral. So that's my process. I've offered various treatments because of the small. My Gleason was a mixture of 6 and 7. I think I am confused by the numbers. I'm sure the professor will agree with me that all these numbers that they throw at you, they are quite confusing, and they do need explaining properly by a surgeon, because I forget things at my age. It was a difficult time as well, So.
Yeah, of course. Can I just ask as well, before we get into the treatment, about like psychologically how that was for you? Because like I say, a 2-month period is quick, and if you only went in with lower back pain to be escalated within 2 months to that diagnosis, like how did you deal with that, and what support did you need around you to help?
Yeah, I dealt with it my own way, which was there was me, and then there was this other person who was who wasn't well, and I wasn't that other person. I had to function in my world with what was going on, and I just sort of parked it up. I was aware of it, but I didn't try and dwell. I tried to be positive and just get on with life as best I could. And this is in COVID time, so we were all living under strange world, shall we say, locked in at home. So I found it quite okay. But again, my father died at 84 with prostate cancer, but it was not what killed him. He was never treated for anything. He never needed treatment. So everybody has different levels, I'm sure. And I was of a view that my father had it, I can have it, and he survived to 84, and I'd be very happy to do that, you know.
Yeah, of course. It sounds like, I mean, as if there wasn't enough going on for everyone this time last year. You had a pretty huge amount to deal with. But so your diagnosis process took sort of 1.5 to 2 months. Would you be able to talk to us a little bit about what your treatment process was, and again, over what period that was too?
Yeah, of course. I was first offered. I was offered 3 types of treatments. I was offered cryotherapy, I was offered removal, and I was offered radiotherapy. And I was a candidate for all 3. I was referred to 3 different surgeons to have each option described to me perfectly as what the outcomes would be and what was suitable, and also all the side effects and everything to go. I'm sure a professor will agree, everybody involved with prostate cancer, they're all lovely people, and they're all looking out for the patients all the time. So I saw 3 different guys who get made 3 different options, and they were all plausible, they were all good results, and I could have gone either way. Anyway, my treatment I chose was cryotherapy, but unfortunately, again, probably because of COVID, it couldn't happen up in North Wales. I could only go to London for it. And I opted eventually, when we couldn't get the cryotherapy into North Wales, and I had to go second option, which was the radiotherapy. Luckily, because again, I have health insurance with Vitality, I was offered Sabre, which is a more intensive radiotherapy, whereby it's a weekly treat. You have markers put on the prostate in the area where the cancer is. Those markers are a gold leaf, and they focus the radiation into that point, so you can have it in a shorter period. So I had five doses spread over a week, rather than the old-fashioned way, as they called it, of 20 doses. So that to me was a great result. I had that done in Liverpool, and I can just sing the praises of how easy it was and how well supported I was in Liverpool when I went there. Everything was straightforward. I had no side effects. I think I'm very lucky in that respect. And even weeks afterwards, again, no side effects of note, other than needing to go to the toilet a bit more often, a bit quicker,
Yeah, I mean, first, it's amazing to hear that was your experience. You look brilliant as well, and I'm really glad that things have gone the way they are. Just for me, did you say 5 doses in 1 week, and that was your whole treatment?
That was my whole treatment. That was something called Sabre, which is the current and the best treatment that was on offer through radiotherapy. So I'm sure the professor could, maybe enlighten people to that a bit more than I can. I'm not qualified, and I might miss something.
Yeah.
No, I think there have been huge developments in radiotherapy in the last 10 or 20 years, and the ability to get all the radiation just to that small place in the prostate gland without damaging everything on the way and everything beyond and everything round about it it makes things like radiotherapy treatment on its own feasible. And a similar thing happened in breast cancer. The results of a trial were pushed through during lockdown to show that for a lot of patients, a week of treatment was just as good as 3 weeks of treatment. So sometimes these catastrophic things like pandemics actually accelerate improvements and developments in healthcare treatment. And I'm also aware of Portuguese research that's looking at single dose treatments to the prostate and other glands. So it is possible that this could go on to be developed even further. But it sounds like my understanding of the scores you said, Chris, were that this is quite an early stage cancer. So it's great that you were able to discuss options and discuss them fully with different people, so to help you make a decision.
Yeah, I'm not sure it's the same in the rest of the country, but with a surgeon I saw, Professor Shergill, up in North Wales, it was a case of he was my main point of contact, but he referred me to 2 separate doctors over on the Wirral through Clatterbridge, and they explained all the options that were available. And I felt that helped massively. Initially, one surgeon's, brilliant as it was, you just wanted more information and a second opinion. You know, you always think you want a second opinion. I was given 3 opinions, and every one was so plausible. I could have gone any which way. So I feel I was lucky in the treatment. I was lucky I was caught early, and I say to all my friends, anybody I talk to, just get a PSA. In your 50s, you should just do it automatically. It's harmless. It doesn't hurt. Just do it.
That's the message. That's exactly it. Gordon, may I ask you this one? I think the thing that we learned about the women's cancer webinar that we did last month was that actually it was a challenge at times, because the 2 members that we spoke to that had been through cancer treatment were given options. And Chris, you've mentioned there about how you were given options, but there was a full explanation associated with that. I think it's something that when you're diagnosed with cancer, obviously I don't know this, but the last thing that you can do is think straight. So how does it work with the consultants and the surgeons? Will they advise and say, we recommend this, or is it a case of generally they'll give you options and you have to decide? Because that feels like a pretty tough decision to make.
Yeah, for myself, I was given 3 different surgeons offered me 3 alternatives for treatment, and each one focused only on that treatment. I think I don't know whether this is something that my professor had set up or whether it was just something that happens automatically. Maybe Professor can tell me, but it just seemed a natural and a good way of doing it, because you were given all the facts by 3 different people in 3 different ways. Forward, I could have gone any option the way it was described to me, and I just went away and thought about it for a few weeks, and then came back and gave my decision.
Cool. Okay. Gordon, do you have any insight on that?
It just shows how far specialization has come. You know, 30 years ago, all urologists would have removed a prostate gland. Now, within a urology team of consultants, there'll be someone who focuses on prostate cancer, somebody who does bladder cancer, somebody who does kidney cancer. And now it sounds like that, you know, within the prostate cancer group of consultants, there are people who will have significant expertise in each of the different ways of treating that. Perhaps not in one hospital, but maybe in a region. And so I think it just shows that drive forward for personalized treatment, you know, makes a big difference to outcome.
Yeah, for sure. Chris, you've been very generous to share your story, and I think I'll be honest with everyone here, we reached out to a lot of people to ask if they would share and join us today, men, and the response wasn't great. And I think that's not negative on them, it's men in general. We're not that great at this, and I think it's recognized, and it's the story that you share adds so much weight to what Gordon and I were saying before. So I know you've already said there, men in 50s, get your PCA test done. Is there anything else that you'd like to share with our audience, just to say, this is what I've experienced, this is what I say to you?
No, I just reiterate, if you have any doubts whatsoever, just speak to your GP. They're brilliant. They will listen to you. They're so understanding. And then from there on, just go with it. Just don't be scared. There's nothing to be scared of. The worst part of the whole process for me was the biopsy. The biopsy is the worst part, and that's very, very manageable. It's nothing uncomfortable. It's done in a day, and after that, nothing else hurts. And even that doesn't hurt. There's no pain. It's just so comfortable to get it done. There's nothing to be scared of. Just go do it.
Amazing. And it's really good to hear you say that as well. It's a nice story, and I think, like you said, Gordon, we don't want to put an overly positive spin on this session. It's not about that, but there are advancements being made, and Chris is an example of where the progress has been made. Is there any final words or anything from you that you'd like to wrap up with?
Just to say that I think Chris's symptoms fall into that unexplained and prolonged category. And so it's a shining example of what we should all do if you know, we're in a similar position.
Perfect. I think there's been a lot of questions that we've had today, and I appreciate we haven't been able to get to the specific ones necessarily. But again, if you've got a specific question that you've asked here and it hasn't been answered, please do go and get it checked out. Speak to the medical professionals, and they will be able to help. And outside of that, again, go to the handout section and download what we've got there. I think with more awareness, lives really can be saved, and it's that important. We all have a role to play, and Chris has shared his story, but there's supporting others and understanding others. That's a way that we can all make a difference. And I say this every time that we do a session on cancer. I have a really cool job. We get to do some amazing things, talks about some really interesting topics, but this is the most important stuff that we'll ever do. So I really do hope that everyone today watching, we've supported you, we've helped you in some way. There'll be a feedback form that will pop up at the end of the session when we finish. So please do let us know your thoughts. We always want to do better, and we really do want to make an impact. So the final thing, I guess, is Chris, again, so good to see you doing so well and hear that your story has gone well. Hopefully we'll do some more with you again in the future. And Gordon, thank you always for your insight and knowledge and sharing your time, because it makes such a massive difference with everyone watching.
Thank you.
Thank you. Yeah, no problem.
Amazing. In the meantime, for everyone else, thank you also for joining us. Take care, and please do get in touch, and we hopefully will see you again very soon. Enjoy your afternoon.